In this session, I will be discussing about the various types of diabetes in pregnancy, the effect of pregnancy on carbohydrate metabolism, and how diabetes affects the mother and the fetus. Pregnant women with diabetes may be grouped into two. The first group, who already know they are diabetic before pregnancy. We call them pre-gestational diabetes or PGDM. They may be either insulin deficient or type 1 diabetic, which may be a few, and majority may be insulin resistant or type 2 diabetes. Another group is the women who develop diabetes during pregnancy or detect first during pregnancy. They may be again classified into class A1, where the diabetes may be able to control by diet and exercise alone, or if it is class 2, class A2, when it is we need hypoglycemic agent for control of the diabetes. Majority of the women are having gestational diabetes. We may come across rarely other types of diabetes like drug-induced or maturity onset diabetes of the young. And if we consider the prevalence of diabetes in pregnancy, it may come around 10 to 14% in our country. Of these, 90% will be gestational diabetes. We all know that one of the important functions of the placenta is to ensure proper nutrition to the fetus. And the source of nutrition is the mother. And whether the mother is fed or not, the placenta ensures that the fetus gets sufficient amount of nutrition. And glucose being the main nutrition or energy source for the fetus, the placenta ensures continuous supply of glucose to the fetus. So, in a fasting state, the mother may go for a fasting hypoglycemia. What happens when the mother is fed? The placenta offers increased insulin resistance, resulting in postprandial hyperglycemia. When there is hyperglycemia, the maternal pancreas secretes more insulin, resulting in hyperinsulinemia. That is a part of it will be destroyed by the placental insulinase, and in spite of the increase in the insulin secretion, the glucagon secretion is not suppressed, resulting in increase in the hepatic glucose output. So as the mother cannot be able to utilize glucose, she has to depend on fat for energy requirement, resulting in lipolysis and release of ketone bodies. This may result in or prone her for ketoacidosis. So in short, pregnancy is said to be a diabetogenic stage and the mother is having an accelerated starvation stage. So we have said that pregnancy is having a insulin resistant stage or a diabetogenic stage. What is the factors which contribute to insulin resistance in pregnancy? We all know placenta will produce so many steroid hormones, and main is the human placental lactogen. Other hormones like estrogen, progesterone, cortisol, and prolactin also contribute to insulin resistance. And pregnancy is said to be a chronic inflammatory stage. So we can expect the inflammatory factors like TNF-alpha, C-reactive protein, interleukin-6. These also contribute to the insulin resistance in pregnancy. Also, placenta is secreting placental insulinase, which will destroy the hormone insulin. And this diabetogenic hormone found to be peak between 24 to 28 weeks. Hence, DDM develops at this time of pregnancy. And that is a rationale for testing or screening for DDM at 24 and 28 weeks of pregnancy. Not only the pregnancy is a diabetogenic state, but if the woman is already diabetic, pregnancy has its influence on the diabetic state of the woman. It becomes very difficult to control her blood sugar. The insulin requirement increases as pregnancy advances. Repeated blood glucose estimation become mandatory, and she is more prone for ketoacidosis. If the woman already has vascular changes like retinopathy, nephropathy, coronary artery disease, all these may worsen during pregnancy, which needs her proper evaluation during pregnancy of these conditions. Diabetes exerts its effect in pregnancy also. It has adverse effect both on the mother and the fetus. Coming to the maternal effects of diabetes on pregnancy. First and foremost, if the woman is pre-diabetic or pre-gestational diabetic, she is more prone for abortion due to increased chance of congenital anomaly in the fetus. The most common complication that can occur in both type of diabetes, that is GDM as well as PGDM patients, are preterm labor. They are more prone for infection like vaginitis, urinary tract infection, chorioamnionitis, etc. There is a twofold increase in the incidence of preeclampsia. She is more prone for other complications like antepartum hemorrhage, both due to placenta previa and abruption. Abruption due to the increase in the incidence of polyhydramnios and more incidence of preeclampsia make her more prone for abruptia placentae. There is a more chance of antepartum hemorrhage due to placenta previa because there is an increase in the size of the placenta, which may encroach on the lower segment, resulting in increase in incidence of placenta previa also. So both types of antepartum hemorrhage can occur more in a diabetic woman compared to a normoglycic woman. And there is the hyperglycemia will be transferred to the fetus, which may result in polyuria of the fetus, resulting in polyhydramnios or increase in the liquor in the womb. And she is more prone for ketoacidosis. And in the intrapartum period, the large size of the fetus, the polyhydramnios, all may lead to prolonged labor, and the most significant or dreaded complication that can occur in the second stage is a shoulder distortion. She is more prone for birth injuries, and there is more incidence of instrumental delivery and operative delivery, and which increases her risk of postpartum hemorrhage. Postpartum hemorrhage, both traumatic due to increase in the instrumental delivery and birth injuries, and atonic due to the presence of polyhydramnios and large size the baby and large placenta. All this will predispose her for atonic postpartum hemorrhage. Coming to the puerperium, there is more chance of puerperal sepsis, and lactational failure. Diabetes exerts its effect in the fetus as well as adverse effect of the neonate also. In the antepartum period, the fetus develops macrosomia, and even IUGR may be seen in patient who has vasculopathy or has complication of preeclampsia. Other important and dreaded complication is fetal death, which usually occur nearing term. There may be incidence of hypoglycemia in the postnatal period, and there is due to suppression of the surfactant production by the hyperinsulinemia. There is a more chance of developing respiratory distress syndrome even in a term neonate. Due to polycythemia, there is more destruction of the RBC neonatal period, resulting in hyperbilirubinemia and neonatal jaundice. There is polycythemia and other electrolyte imbalance like hypocalcemia, hypomagnesemia can also occur in the neonate, and they are more prone for cardiomyopathy or hypertrophy of the ventricular septum. The baby is also prone for long-term effects like development of hypertension, obesity, metabolic syndrome, insulin resistance, hyperlipidemia, and more from increase in the inflammatory markers and vasculopathy. All these complications can occur in the adult life in a fetus or infant of a diabetic mother. All the effect of diabetes on the newborn and the fetus can be explained by the Pedersen hypothesis. According to that, when there is maternal hyperglycemia, it will be transferred to the fetus causing fetal hyperglycemia. This will result in beta cell hypertrophy of the fetal pancreas and result in hyperinsulinemia in the fetus. It also produces insulin-like growth factors, which will contribute to the macrosomia in the fetus. When there is increase in the growth, there is increased metabolism, more requirement of oxygen. And if the placenta fails to supply or rise in along with the increase in the metabolism, there may result in hypoxia, and baby may suffer from hypoxia. And the fetus tried to compensate by increasing the production of RBC, resulting in polycythemia. This polycythemia will also result in vascular thrombosis in the fetus as well as in the neonate. And in the neonatal period, it may result in jaundice also. Hypoxia will result in placental hypertrophy and edema of the placenta. And when there is hyperglycemia, the resulting hyperinsulinemia in the fetus will block the cortisol production, which will result in suppression of type 2 pneumocyte, resulting in decreased production of surfactant production, which will result in respiratory distress syndrome even in a term baby of a diabetic woman. The hyperglycemia in the fetus also will increase the HbA1c, which has a high affinity to oxygen. So will refuse to part with the oxygen to the fetus, and the tissue will suffer from tissue hypoxia. So all this may result in fetal death. And when after delivery, when the cord is clamped, the maternal source of glucose is cut off, and since there is hyperinsulinemia, the infant will go for hypoglycemia, which may even result in neonatal death. In patients who are having pre-gestational diabetes or over-diabetes, there is an additional common risk of congenital anomalies of the fetus. And this incidence of anomaly correlate with the level of HbA1c or the glycemic control. And the most common anomaly is the cardiovascular anomalies, followed by central nervous system anomaly. One anomaly which is specific to diabetes is caudal regression syndrome, but it is very rare. Uncontrolled diabetes during the embryogenic period can affect any system of the body, the most common being the cardiovascular system, and the most common anomaly is the ventricular septal defect, followed by an atrial septal defect, coarctation of aorta, transpositional great vessels, situs inversus, and phylotetralogy. In the central nervous system, it can result in neural tube defects, anencephaly, microcephaly, hollow prosencephaly, and for the skeletal system can result in caudal regression syndrome and sacral agenesis. Coming to the renal system, there can be renal agenesis, hydronephrosis, double ureter, polycystic kidney. The gastrointestinal system, it may result in duodenal atresia, anorectal atresia, omphalocele, tracheo-esophageal fistula, etc. And there can also result other anomalies are single umbilical artery. To conclude, hyperglycemia adversely affects the fetus and the woman. The risk of complication is proportional to the level of blood glucose. Good glycemic control will bring down the risk to almost comparable to normal glycemic women. Hence, screening for an adequate control of diabetes in pregnancy is mandatory.